All right, we are back live for Julia Harris's second topic on the cost effectiveness of opioid-free anesthesia. I thought the NSAIDs was fantastic. I think in general, NSAIDs are kind of the drug that kind of is a toss away that we don't think too much about, but there's
Right.
obviously some really fascinating stuff going on there and some really interesting, hopefully some more literature coming up here soon.
Yeah, you students get busy.
There you go.
So, yeah.
All right, take it away, Julia.
Okay, great. So this next topic has to do with money. So I'm sure you've all had your cup of coffee by now, and you're ready to listen in to see how you can affect the finances of your hospital, because that generally gets the ear of your administrator very quickly. So here's some data that I did based on research from a couple of years ago, and some of these issues are ongoing. I don't have any conflict of interest for this. When I had time, I was a super big stickler for billing. I do my own billing. Have since 2017. So I have a skill set for understanding finances more than most CRNAs. I don't recommend it for anybody. If you guys want to have a life, don't ever do it. But it is interesting. So I'm not going to start with billing. I'm going to start with costs to the hospital. What do our drugs cost? Does the choices of medication significantly affect the hospital budget? This is a list of medications that are very commonly used in anesthetics. I just got this price list updated in October of 2021. So if you guys are interested, there it is. So what I did is I looked at the total overall cost for traditional or opioid-based anesthetic, and I compared it to what we normally use for opioid-free anesthesia, right? So, and TIVA, by the way, I typically did total IV anesthesia and opioid-free anesthesia together. So I did an analysis, and I broke it down for, basically into two categories. So the first category is price per dosing, i.e. if you can split vials, or you can get your pharmacist to split vials, or somehow that cost can be shared between patients. And then if your institution doesn't allow for any vial splitting and your pharmacist doesn't mix it, then what the actual cost would be. So here for a traditional anesthetic, you see if you were able to split vials, the total cost would be approximately $20.94. And please note that I am using or calculated based on sevoflurane here. And if you're able to split vials, the cost is about $24.20 per anesthetic. And we're talking maybe an hour and a half long anesthetic. We're not talking about a 12-hour anesthetic. So keep that in mind. And I compared that to what the agents that I typically use in my opioid-free anesthesia. And so what I found was if I was able to split vials for my patient, the cost for an anesthetic would be down to $12.37. So it is not only not more expensive, it is less, significantly less, almost half of what it would cost for a traditional anesthetic. And if you were not able to split vials, the cost is similar, but still a little bit less, and that's $23.81. And one of the reasons for this is your ability to dial back your primary agents. So when you're using all these multimodal agents, you can back off either your sevoflurane or your propofol drip or whatever, because these agents have a pretty profound anesthetic effect all of their own. So yes, you're using more agents, but that is allowing you to cut back on other agents. And then, of course, as we're going to be talking about, it reduces postoperative complications, post length of stay, and that kind of thing, which translates into money. But as I have found, administrators, insurance executives, and whatnot focus on what they're paying right now. They're not super interested in potential cost savings or cost savings on the back end. And we'll talk about that too in a little bit. So here's some pricing for nerve blocks. So if you're doing a traditional nerve block, it costs about $7.50. And that's just using ropivacaine and Decadron. A lot of people are using other agents such as dexmedetomidine, I even heard now using magnesium in some of the blocks. I haven't done that yet, and I believe that they're more for fascial plane blocks, but I haven't tried that. So if you're using more agents, clearly your price is going to change a little bit, but that's a drop in the bucket, considering what value you're giving to the patient and avoiding things like return to the hospital for uncontrolled pain or constipation because they've had to take too many opiates and that kind of thing. So, and then looking at the cost of long-term acting nerve blocks. So if you're doing a nerve block catheter, which is what I used to do, the cost was $277, and those blocks lasted 3, 5, and more. In fact, the limiting factor of keeping the catheter in became concerned about infection, not necessarily how long they could work, especially if I was doing like a C5 nerve root block for a total shoulder replacement or something like that. So well worth the cost. Patients didn't like it as much as they liked the Exparel injections. The Exparels lasted approximately 3 days. Well, obviously you get some depreciation of effectiveness over those 3 days. So it's not solid for 3 days, but they like the freedom of not carrying that catheter with them, especially with the total knee replacements that I ended up doing genicular nerve blocks and IPAC blocks for the total knees. And they like the one-time shot and they were able to get out of the hospital really quick with that. So this is the cost. So $277 for the nerve block catheters. And then if you're using Exparel, the price has gone up a little bit this year. So a 20 milliliter vial costs $350, which is, it's hefty. I'm hoping that'll go off patent in not too long. A lot of our drugs have, if you look at that price list for the anesthetic agents that we commonly use, most of them are pretty reasonable. The other anesthetic agent that I would like to see go off patent sooner rather than later, of course, is Zugamidex, and that was touched on yesterday. So, but even pregabalin that used to be on patent not too long ago, and that was like $7 a pill, and now it's down to 20 cents. IV acetaminophen is now off patent. That used to be about $40 for dosing, and now it's down to like $7 a dosing. So we're having those price points come down really allows us to provide better care to our patients because get real. I mean, our pharmacist is not going to let us have all the agents that we're going to want because of price and because of inventory and that kind of thing. So you sometimes need to be the one to argue to your pharmacist that, no, I know it was expensive 5 years ago, but it's off patent, it's more affordable now. Can you please recheck that? And I would like those agents to be available for use for my patients. Another thing that I looked at in my facility was the length of stay for total joint replacements, i.e. total knee replacement. As I indicated, I was giving genicular nerve blocks with long-acting agents, and they really liked that. I even had one patient that had both of her knees done. First time I did it with a indwelling catheter. Second time I did it with the long-acting single injections, and she said by far that the single injections were preferable. So I kept that in mind. So did that make a difference in length of stay, which translates to cost? Yes. Doing the opioid-free anesthesia cocktail and the pre-meds and the post-ops and these blocks really did make a significant difference in length of stay, and that translates to cost savings for the hospital. So I evaluated 94 patients that had net total knee replacements between 2015 and 2018. And then again, I reevaluated in 2019. So I'm giving you the 2019 data. What did I find? Before I started doing the opiate-free anesthesia and doing all these pain management interventions, the length of stay for total knee replacements in that facility was up 2.66 days for traditional care. Then once I started implementing these pain management techniques, it decreased to 1.27 days, which is pretty phenomenal. So that's 1.39 days decreased length of stay for each patient. And our facility was pretty small, which translates to, every dollar counts. But if you think about that financial impact on larger institutions, or what that would mean cumulatively, that's pretty profound. And I did some calculations here so what that would actually mean in actual cost savings or adjusted cost savings. So there are several different price points of how much it costs for patients to be in the hospital. So, and I'm sorry, I should probably preface this if maybe people don't know that for total joint replacements, the insurance company typically pays the hospital a bundle fee. So you're not getting paid for your your operation and then your every Tylenol pill, every day you stay in the hospital, or any of the things related to the process of you having your total joint replacement as far as the hospital costs. You are given one bundled fee, whether that be $19,000 or $25,000 or whatever. So your hospital will negotiate with the insurance as to how much that bundle payment is going to be. And then the hospital also has some skin in the game, right? So they have an incentive to get the patient home sooner because they're going to save money, and they're going to be able to make a bigger profit. And then, but if they don't do a good job and the patient ends up staying in the hospital or going to like a long-term nursing care facility, the hospital's on the hook to pay for that. So, the change in incentives is key here. And this is why getting the patients home sooner means such a big deal to the institution. And remind you, this is just cost savings. This doesn't include the money that the hospital would gain if they were able to fill that bed with another patient because it was vacant. So that would be an additional cost revenue, really. So you could increase these values by another 150%, I would say, at least. So we actually be 3 times the value here that I'm showing. So at a very, very conservative cost estimate, each patient going home early translate to $1,355. At the least conservative estimate, each patient would save the hospital $3,441. So again, it depends on which source you're looking at when it translates to how much cost saving it is. But so I was looking at 26 surgeries that these patients had these interventions for my little hospital that I was covering. He said that's almost $50,000, which is significant for that little place. And then for if you were looking at the least conservative estimate, that's up to $124,000 just for 26 patients. And again, you can triple that if you were looking at income for the hospital. So they had potential income much greater than their cost savings. So your interventions really do count in terms of finances of the hospital, and it would behoove you to make your administration aware of this. Now, I also looked at how the patients did in recovery when they got opioid-free anesthesia versus non-opioid-free anesthesia. And I looked at 82 patients, 24 of which had opioid-free anesthesia, 30 of which had, 82 patients on each. I'm sorry. So 164 patients total, 82 patients in each group. And I looked at, whether or not the patient had any opiates, and if they did receive opiates, how much did they receive, and what were their Aldrete scores in the recovery unit on arrival and on discharge. So what I found was that less patients needed any kind of opioid rescue if they had opioid-free anesthesia. And if they did receive opiates, they needed significantly less. So if the number of patients that were given opiates in PACU in the opioid-free anesthesia group was 24. The number of patients that were given opiates in the traditional or opioid-based anesthetics were 30 patients. So that's pretty significantly different. And I think the most notable is how much they got. So in the opioid-free anesthesia group, if they did receive opiates in the recovery, it was equivalent to like 29 milligrams. But in the traditional opioid-based anesthetic, it was 45 milligrams. And that really speaks to what we know about opiates causing hyperalgesia and tolerance. So if we're giving these heavy duty opiates while the patient is under a general anesthetic and they're having nociception, and we're controlling their sympathetic response by giving them opioids, which control pain, which is nociception and emotion, but the patient's under anesthesia, they don't really have emotion, but we're still treating their nociception with an opioid, you're going to pay the price later, right? So patients are going to experience greater pain in recovery, and I think these numbers speak to that. So it would behoove you to control their sympathetic response otherwise, and to control their pain via non-opioid modalities. And then if they need opiates afterwards, if you've given them everything else, then you go ahead and give it. And when you do give it, you'll notice they need significantly less. And they're, as far as the recovery scores, they were pretty similar. In fact, the opioid-free anesthesia patients were more awake when they were discharged. Originally, when they come into PACU, they're a little bit more groggy, or the nurse interprets them to be a little bit more groggy because their response is just a little bit different when you give them dexmedetomidine. So their score was a little bit lower when they got there, but recovered, and then some when they discharged. So they had a higher score. So the other thing that happened when I asked all my providers to start using opioid-free anesthesia. And I was able to get buy-in from all my providers, which I'm very grateful for them for their willingness. I watched them. They were willing to participate, but I noticed they were kind of stressed out in between cases trying to draw out these medications on these different doses. And it's just a little bit, it's more of a process, and the charting was a lot. I had to scratch out the fentanyl and write in Precedex and this kind of thing. So through that experience, I figured out ways to simplify and streamline how my providers are able to perform this in a way that's not overly burdensome to them. So I did a few things. I standardized my medication, both the preloading dose and the intraoperative dose. So I was able to find a formulation where basically 1 cc, I would give 1 cc of the pre-op loading dose per 10 kilogram patient weight, and I would infuse it over a few minutes. But we'd always draw up the same syringe with the same amount of medication. The only variance was how much they weighed. So I did that, and then the doses that I normally gave to my patients, I instead of mixing it per patient based on weight days and then diluting it, I would put the same amount of medication in the bag and then just change the drift rate, which I gave the patients, which that was really, really helpful. Really, really helpful. So you can basically draw up all your medications, ahead of time without knowing the patient's weight. And then you change the infusion rate based on the patient's weight, ideal body weight, and age, as was noted yesterday. I also developed IV labels for the syringes and the bags. That made it a lot easier instead of writing down all the individual ingredients. This was the old charting system. As you can see, I almost crossed out every single line to write out the drugs that I was giving. So instead of asking my providers to that, I just made a new anesthesia form. And yes, we were on paper charting, which I know is archaic for many of you, but that's the way it was. So I changed the anesthesia record. So they actually didn't have to write in the infusion. The infusion was already pre-printed. They would just check it, and they would check what bag they use, like, because of the ketamine. So instead of having to calculate all the ketamine, I had a negotiation with my pharmacist. They would just write the total amount of the infusion given and call it a day. So they didn't have to, waste 22.5 milligrams of ketamine or whatever. So that made things a lot easier. And I think my patients were, or not patients, excuse me, my team members were much less stressed once I started implementing those things. And we were able to get rid of the opiates in the narcotic box. They were still inaccessible in case there was a need for them. But since I wasn't using them ever, I didn't have to count them every day. So we took them out of that. And so, as I told you, I was pre-mixing these bags so that we could just change the rate of the infusion and not have to mix the individual patient dosing as a patient came in. I thought, well, what a great idea. It would make it even easier for if my pharmacist was able to mix these up pre-op. Weren't having any of it. They didn't want any of that. So I started looking into having it pre-mixed at other facilities, and there is definitely a cost associated to that. I called CAPS and was like, "Hey, would you make this for us?" And like, "Yeah, but it would take like $200,000 worth of stability testing, and then we'd have to put it in our log and like sell it to everybody else, and basically you wouldn't have any rights to it anyway." I'm like, "Yeah, that's not very realistic." So I haven't completely resolved that problem, but I do understand the process a whole lot better. And this particular incident is why the pharmacist was so resistant to admixing the medication, and it was related to the New England incidents, which happened in 2013. Some of you might remember this. It had to do with a compounding pharmacy and contaminated steroids, which ended up causing the death of 76 patients. And 800 patients became very, very sick from contamination of compounded agents. So once that happened, there was kind of like a pendulum swing completely to the other side, where it became overly restrictive and basically makes it unrealistic or for me to ask my pharmacist to do this, because there's so much regulation around it. And another thing that happened was I started billing for opioid-free anesthesia. I told you I have some billing experience, so I thought, well, I have two interests and I have a skill set. Why don't I kind of bridge the two and pioneer this idea of billing insurance companies for services that we provide that are above and beyond, and that produce better outcomes for their patients and cause less money on their back end, such as chronic pain syndromes and chronic opioid use and that kind of thing. So I just figured it would be a good catalyst for other providers to adapt this practice, because normally it takes 15 to 20 years for a new practice to be integrated into everyday medical practice. And we just don't have time for that in the United States. So many people are dying from opioid use disorder, and people are suffering from chronic pain syndromes. If we have the ability to alter that for at least some patients, I think that is a heavy burden for us. And I think that is our responsibility to alter our practice to make sure that doesn't happen, or doesn't happen to as many people. So again, using opioid-free anesthesia, my take is not that if you're exposing the person to fentanyl once, that they suddenly are chasing the dragon after surgery and they're going to line up out the street to try to get fentanyl on the street, but rather you're very diligent and you're very focused on the way that you control pain. Pain is tackled before it even starts. So you're not chasing it you're not trying to cover up pain. You're changing the inflammatory process, or you're really minimizing the inflammatory process of suppressing that so that the pain doesn't start in the first place. And so it's much more of a preemptive sort of a philosophy, and patients post-operatively do better, as you can see from the studies that I have shown. And so that's what it is. If you're doing a better job of controlling post-operative pain, they're not going to need so much Percocet, right? They're not going to need such much post-operative pain management. And that is where the danger comes in, as far as getting in this very basic human cycle that we're all susceptible to in terms of addiction. It's a real phenomenon, and we're all susceptible to it. So it's our job to help people not get there in the first place. So why should insurance companies pay for OFA? I think we talked about that a little bit. Preventing, putting some money out in the front end and trying to prevent really costly and terrible things happening on the back end. Unfortunately, again, administrators and insurance companies are very much focused on their bill right here and right now. They somehow have a really difficult time understanding or valuing potential cost savings. So I don't know what to tell you about it. It's really hard. But one thing is helpful is these lawsuits that have happened against Big Pharma. So indicating that complacency leads to liability. So you can't just shrug your shoulders and say that it's not your responsibility, that, you know, you're sorry that these things happened. You know, if you're not doing something about it to actively combat it, you're part of the problem. So that is one of the arguments that I'm making to insurance companies. And I would say you as a provider, that should make you think twice. It really should. So, and I hope it does. Another thing that is really compelling is this pain management best practices task force that came out in 2019 that stated that it encourages the CMS and private payers to reimburse for multimodal approaches in acute pain in the perioperative and peri-injury settings. And it lists specifically ketamine drips, lidocaine drips, and those kinds of things, which is are core components of opioid-free anesthesia. So this was a gold finding, and Bruce Schonenborn was actually on this committee. He was the only nurse, he was the only CRNA and the only nurse on that committee. So kudos to him. And I saw in reading the notes that he actually was one of the people that encouraged CMS to reimburse for, didn't say opioid-free anesthesia, but these multimodal modalities. So kudos to him. That was very timely and very important. So when you're billing for opioid-free anesthesia, you got to really keep in mind what it is that you're billing for. So it's not just the removal of opiates from your practice. You're actually replacing them with several medications that can modulate pain and do it preemptively. So you're giving the oral medications, you're giving the loading dose, you're either giving a continuous fusion in intra-op, or you're giving several IV boluses. So you're doing everything you can to modulate pain before pain starts. And that's a really key component when you're talking about billing for opioid-free anesthesia. So I have a couple of graphs like this. I will make these slides available to you. But what I want to really highlight is that in order to get paid for opioid-free anesthesia, you need to do the intervention of opioid-free anesthesia. If you're giving a traditional, if you're giving anesthesia, you're going to be billing for the primary anesthetic, the base units. You're going to be billing for the time units. That's totally normal. If you're giving a block, you're giving a block for postoperative pain. That is the reason why you're giving and able to be reimbursed for a postoperative block. It has to be intended for postoperative pain. That's identified by the modifier 59 that says a separate procedure. If you are using your block to facilitate your anesthetic, or that is your primary anesthetic, and you're not giving a general anesthetic or a spinal on top of it, guess what? You're not supposed to be billing for postoperative pain measure. You're not supposed to be billing for the peripheral nerve block if the intent is to be used for intraoperative pain management. So I think that is key when you're thinking about reimbursing for opioid-free anesthesia. Your block is supposed to be for postoperative pain management. The opioid-free anesthesia, again, works on all those inflammatory mediators that we talked in the non-steroidal anti-inflammatory lecture, and you are actively modulating that inflammatory pathway and controlling pain with the NMDA receptors and whatnot. So it is a completely separate intervention. So you're not just excluding opiates, you're also managing pain in two ways. If you're giving a block, you're doing the intervention of a block, and you should get paid for the block for postoperative pain management. If you're doing the opioid-free anesthesia protocol, which is extensive, again, giving the preoperative oral medications, giving the loading dose, and giving medications intraoperative, that is a whole nother work set, and you should be reimbursed for that. And that is when you're charging for opioid-free anesthesia. If you are giving a general anesthetic and you are giving a block and you're not giving opiates, you're going to bill for your anesthetic and you're going to get billed for your block. You're not going to be billing for opioid-free anesthesia protocol because you didn't do another intervention. So you are only to be paid for the interventions that you do. And if you're not doing anything special or different, with your anesthetic, then you are not going to be paid for that. You shouldn't be billing for that. So that is the main take-home point for this slide, and also for one more. So I'll skip over that when I get there. We talked about nerve blocks, and we talked about this. So I will make this available to you to look at in case you have any other questions. Main take-home point is that Medicare. So Medicare is a holy grail for insurance reimbursement. Why? Because it sets the standards for all other insurance companies, basically. So if Blue Cross Blue Shield is wanting to not pay for sedation for, say, cataract someday, they'll look to Medicare and see if Medicare is reimbursing for not. If Medicare stops reimbursing for sedation for cataracts, guess what? Every other insurance company out there is going to stop reimbursing for sedation for cataracts. That's just an example. So when insurance companies are questioning whether or not to do, to reimburse for something, they look to Medicare first to see if they're reimbursing for it or not. They set the bar, they set the standard for all other healthcare insurance informations or insurance companies in terms of billing. So that is why Medicare is so important. And I have spent a lot of time trying to get Medicare to reimburse for opioid-free anesthesia. So I spent a lot of time. Sarah knows how much time I spent. Well, no, she might not actually know, but anyway, it's a lot. I'll be publishing the results of the billing for opioid-free anesthesia in the next few months, and Sarah's integral into that, and she'll be my co-author. Anyway, so Sarah and I started by writing a letter to Noridian about why they should reimburse for anesthesia. I had already talked to multiple supervisors. I had talked to Tom Baribold, and got the most recent compelling literature for reimbursement for opioid-free anesthesia. And I was super excited to be providing this information to Noridian as to why they should be reimbursing for opioid-free anesthesia after I sent them their first bill for opioid-free anesthesia. And so what happened? I sent the letter to Noridian and the supporting documents which were forwarded to the contract medical director. And the contract medical director is like the big cheese boss. It's more on CMS. So it's not just Noridian. So Noridian covers California and Hawaii and a couple other places, but that's the MAC of Medicare. So the big cheese contract medical director is higher up. So they are involved in multiple MACs. So in multiple, it's more nationwide versus just state. So they asked the contract medical director about this stuff. So what does a contract medical director do? Picks up the phone and calls ASA. Says, hey, this person is billing for opioid-free anesthesia. What are your thoughts? And so the ASA says, well, we're trending to that anyway. We're reducing opiates anyway, so there's no real need to reimburse for that service. So there was no name, there was no position. It could have been a secretary for all I know, but that was the response that CMS gave to me. They called CMS, and whoever answered the phone said that it wasn't necessary. So I'm like, okay, well, actually it is, but we'll get there. So I built another case off, and by then I had kind of figured out the coding a little bit better, so I had less glitches with getting the bill through. So that was really good. And because there's no specific anesthesia code for opioid-free anesthesia, you have to explain everything. You have to explain what it is. It's not understood right away when you're billing with this code. They don't know what it is. So you have to send that letter in, and it went to the adjudication process, or the process where they hand look at it. So this billing supervisor, who was an RN, contacted me and said, hey, can we go over this anesthesia record with you? I'd like to know what interventions you're doing. So I did have a conversation with her and a billing coding experts for Noridian. And lo and behold, I got my first payment. So Medicare allowed $100 for opioid-free anesthesia. And so they paid $80 of it. And then the 20 gets paid either by the patient or the second insurance. So that was a huge win because, again, Medicare sets the stage for all of their insurance payers. So that was phenomenal. I was still having a lot of hit or misses. There was a lot that happened between that first payment and this letter that I received from Noridian. a year or so later, stating that Noridian recognizes opioid-free anesthesia as a separate reimbursable procedure to Medicare, which is huge. So again, Noridian is one MAC of Medicare. I want all of Medicare to reimburse for these services. And that's a huge ask. There's several things that need to happen. Probably before that happens, we need to get a specific CPT code, and I'll talk a little bit about that later. And before that, it might need to be analyzed for RVUs, or how much work is involved in providing opioid-free anesthesia and how that translates to dollars. So those things have a whole process of its own. But I have been bugging CMS about publishing on billing for opioid-free anesthesia, because that's what it's going to take for billers and providers to be comfortable billing for opioid-free anesthesia, because there is this concern that you're falsely billing or you're billing twice for the same thing, because it's very unusual to use two anesthesia codes to reimburse for anything related to primary anesthetic. I have a whole lecture on just billing for opioid-free anesthesia, and I won't do that for time's sake, obviously. I will tell you that I have talked to Dr. Sherry Ling for the last year and a half, who's a deputy CMS of Medicare, and hadn't gotten very far. So I upped the ante a little bit and ended up talking to or communicating with Dr. Lee Fletcher, who is the chief medical officer and director of CMS, very, very, very briefly. And I was thrilled that he answered my emails. He didn't say what I wanted to hear, but I will continue up with him. Since he's an anesthesiologist, he is accused of any anesthesia-related payment decisions. So that's very problematic, but there's got to be a way. All right, so this is a tally from 2020, the summer of 2020. And this gives the information of what insurance companies are paying for opioid-free anesthesia and how often they are paying for opioid-free anesthesia. So there's a huge variance. And again, I would look to Medicare for being kind of the common denominator, or how much to expect for reimbursement. So some terrible reimbursement, HMOs, 6% reimbursement on HMO. United Healthcare is dismal, only 14%. Anthem's even worse, 5%. Aetna is good, but I've only had two of them in my pilot study. Blue Shield was actually pretty good on the reimbursement. It reimbursed $214, and they reimbursed 95% of the time out of 21 cases. Now, mind you, some of these, I couldn't use all of the bills that I sent out because I was still learning how to correctly code and to get the bill transmitted electronically and that kind of a thing. So I wasn't able to include all of the bills that I sent out. I'll be the first to admit that I did lose some money in this experiment because I wasn't able to get all the claims through, and I didn't get reimbursed for some of them. But now I've got it worked out, and so I'm pretty confident that none of the bills will be rejected because of the coding. I won't expect to get reimbursed all the time, obviously, though. So, and this is the kind of the summation of the percentile of reimbursement. So 54% of the time that I sent out a bill, I was reimbursed for opioid-free anesthesia, which is pretty good. Average payment, $448, very good. It had to do with my payer mix, though. So you got to keep that in mind. That's most insurance companies paid some. Commercial insurance, I would say the expectation to be around $200. I think that's pretty reasonable. And the total that were billed that were included in this analysis was 390 bills. Don't be excited, don't expect your biller to be very excited about it. It's fraught with problems. If you are providing opioid-free anesthesia and you're interested in billing for opioid-free anesthesia, please contact me. And I will do my best to help you out with that. Again, you need to do all of the processes. So you need to be giving the preoperative anti-inflammatory medication, or pro-analgesia medications. You need to be given the loading dose. You need to be giving an infusion or frequent bolus doses intra-op. You cannot just do your regular anesthetic and not give opiates and bill for opioid-free anesthesia. You cannot do that. You're not doing another intervention, and therefore you should not be paid. And I would argue that you will be in trouble if you start billing for that, if you're not providing the opioid-free analgesics. So anyway, there's a lot of things that you can do to kind of spin this in your favor when you are billing. Again, if you are wanting to bill, please contact me. If you are providing opioid-free anesthesia, again, don't misuse this code. Even though I do opioid-free anesthesia, don't use opiates on a number of cases. No, I'm not going to bill it for a case that doesn't have significant postoperative pain. So obviously not billing for cataracts, not going to be billing for endoscopies or anything else that you wouldn't be worried about some moderate to severe pain afterwards. All right, so I talked about the CPT code. I need to wrap it up because we're just about done with our time. But again, I'm using a non-specific anesthesia code in order to bill for this. When the insurance companies get this, they have no idea what to do with it. It can't just fly through their billing process and have it automated. Somebody actually has to look at it and then decide on an individual basis whether or not they're going to reimburse for it. So this bill or this service needs to be tied with a code that identifies it as such. So there needs to be a CPT code for opioid-free anesthesia, and that there's a huge process to that. And I have talked to every stakeholder here because the AMA has a panel basically that decides whether or not a procedure gets its own CPT code. And, you know, friendly AMA, that's going to go well if I just go up to them and say, hey, I've got this great idea. Yeah, talked to a lot of people about this. Anyway, so there are several people on the panel. There's 11 people, but there are 4 external people from the AMA, excuse me, and that is Blue Cross Blue Shield Association. I've talked with them up the yin yang, and last I heard from them, they're like, well, more people need to be billing for opioid-free anesthesia before we'll, you know, write anything, any advisory letter or anything within Blue Cross Blue Shield. I did end up having a conference call that I believe the member of the panel was on that call, but it was very brief. And the chief medical officer who found out that I was not a physician, once she found out I was not a physician, I was not very well respected. I wasn't responded to very well, unfortunately. So I did go that path. I haven't gotten very far. I talked to the American Association of Health Plans. That has been very, very helpful and has been instrumental in key contacts, and I will continue to work with them. The American Hospital Association basically like patted me on the head and told me to go talk to the AMA or the ASA or the AANA because they'll handle it. Well, I have talked to the AANA. I'm not going to go talk to the ASA, but I talked to the AANA, and they don't know the process for applying for a CPT code. They're very encouraging. They say, you know, pat me on the back, go for it. And I think that they would provide what other resources that they have readily available, but this process is novel to them. They don't have a process in place to do this. So so I am the expert on opioid-free anesthesia in terms of the AANA. So I'm hoping to continue that conversation as the time comes. Just having the AANA backing when I'm having these conversations does make things go a little bit smoother, depending if you're talking to anesthesiologists or not, obviously. But you know, that makes me look less like a rogue person trying to get more money for myself. This is an effort to have other providers get reimbursed for opioid-free anesthesia. And so having the AANA on those conversations helps that message get across. CMS, I told you, I have ongoing conversations with them. And one of the things to getting to bringing this to the panel is you need to have somebody that's in your corner. So I'm really working on trying to find that person that is interested in bringing this forward to the rest of the panel. And that's a tall order. So I'm working on it. I'm trying. It's hard. It's usually something that industries hire like experts to do. I'm trying to figure this out on my own, but it'll take some time. Anyway, so how might OFA be reimbursed? So I see in the future that it being tied maybe to how complex the case is. If you're doing an open bowel case, you will probably get reimbursed more than if you're doing, you know, an orthopedic case or something like that. You know, much like the CPT code, if you'd be somehow tied to the CPT code, where the more complex the case is, the higher the unit value. But that's all tied to the RVU process that I talked about, you know, how many dollars should be tied to this process. I also can see the reimbursement for the ultrasound guided block being bundled into this opioid-free anesthesia charge. Now that'll only be possible or palatable if they pay us enough for the opioid-free anesthesia charge. You know, it's not going to be awesome if they pay us $5 more than the block and then stop paying for the block. So, but I can see that happening, them kind of bundling those services together. And again, my forward thinking is I need to get CMS to reimburse for it nationwide. We need to get a CPT code. One step that I really am interested in is getting the surgeons on board with prescribing non-opioid pain management modalities post-operatively. We do this beautiful opioid-free anesthetic, and then they send them home with 30 opioid pills and then prescribe them as, you know, re-prescribe as needed. I mean, how valuable is it, our efforts, unless a patient really is motivated on their own? I mean, I think it makes a difference, but I think it would be more of a difference if the patient was sent home with pill packets or those aluminum foil like pop-out pills for regular regime of non-opioid pain medication. So that is a missing piece of this puzzle, but I don't think that is something that we can solve right away. But I think that's going to make a huge difference on the rate at which surgical patients, not opioid naive patients that undergo elective surgeries, are going to have a decreased rate of opioid use disorder postoperatively if we do this. Currently, it's 1 in every 10 patients that are opioid naive going into elective surgeries that end up with opioid use disorder. And that's pretty heavy. We can do something about that. So that's the end of my presentation. And I thank you for your time. And I don't know that we have any time for questions right now, but this is my email. You're more than welcome to email me any questions.
All right. Thank you, Julia, for all that you did in this presentation preparing for it. And I had just no clue the trails that you were blazing as far as the reimbursement for opioid. When I was thinking of this topic, I was thinking more like how much does it cost propofol versus SIBO, or, you know, fentanyl versus ketamine. But I mean, that is a ton of work. And I know those industries are not easy to work with. So.
Oh, Lord. No, they're not. I thank you for that. Yeah, it has been my passion. And I've spent a considerable amount of time and effort on that. So thank you for recognizing it.